Welcome to the deep dive. And if you are a medical student prepping for your pathology exams, or maybe a junior doctor navigating the medico-legal realities of the emergency department, or even a senior clinician looking to really solidify your forensic foundations, well, we are incredibly glad you're joining us.
Yeah, you are exactly who this session is engineered for. We know the demands of clinical practice and rigorous study mean your time is highly valuable. You need information that is structured, precise, and most importantly, anchored to actual clinical reasoning rather than just, memorization.
Right, exactly. So our mission today is a comprehensive conceptual deep dive into the forensic medical principles surrounding torture and cruel, inhuman, and degrading treatment. And we're using Simpson's Forensic Medicine, specifically Chapter 20, as our structural spine for this whole discussion.
But before we go any further, let's just establish a really clear disclaimer. This audio session is a conceptual framework designed to support your reading. It is absolutely not a regurgitation of the book.
Definitely not.
And it does not replace the text. We strongly encourage you to literally open Chapter 20 in Simpson's and read it alongside this session to truly lock in the knowledge.
We're basically here to help you build that clinical scaffolding. We want to connect the mechanical force of an injury to the physiological finding, then map that finding to its forensic interpretation, and finally connect it to its legal implication under international law.
Because when you grasp the underlying mechanisms, the necessary documentation discipline just naturally follows.
It really does. And the hook for today's topic is an essential paradigm shift. I mean, when most medical professionals think of forensic medicine, the immediate association is usually local criminal courts or sudden death investigations, standard autopsies.
A local coroner's office, basically.
Exactly. But forensic medicine does not stop at the jurisdiction of the local coroner. It stands at the absolute frontier of international human rights.
It really does. The forensic practitioner frequently serves as the absolute linchpin in asylum claims, international tribunals, and global human rights investigations.
And regarding our tone today, it will be strictly objective and scientifically impartial, as all forensic disciplines demand.
But we should clarify that objectivity does not equate to an absence of ethics. The work is firmly grounded in the protection of human dignity.
Yeah, and there is a central, really haunting principle in this field that we must establish immediately. It's basically the lens through which you must view every single patient encounter in this context.
Absence of visible evidence of maltreatment is not evidence of absence of maltreatment.
That is the golden rule. Absence of visible evidence is not evidence of absence. I mean, the biological reality of human tissue is that it heals.
Right.
And the legal reality is that perpetrators specifically choose modalities designed to leave minimal trace. So let's start by looking at the global landscape. Why is this so critical for a clinician who might just be working at a standard city hospital or a quiet suburban clinic?
Well, because the prevalence is staggering. Despite the absolute prohibition of torture in international human rights and humanitarian law under all circumstances, and I mean with no exceptions for war or public emergency, it is still actively believed to be practiced in over 100 countries.
Over 100 countries, which means the statistical likelihood of you encountering a survivor is incredibly high, regardless of where you practice. You might be evaluating a patient in local police custody. You might be working in an immigration detention center.
Or conducting intake at an asylum clinic.
Right, or simply managing a busy Friday night in a local emergency department.
The global movement of displaced persons practically guarantees that frontline healthcare workers will intercept these cases. And the impact we are looking for is dual-layered.
What do you mean by dual-layered?
Well, first, there is the profound, devastating physical and psychological trauma inflicted on the individual patient sitting in front of you. But there is also a macro-level impact that your forensic documentation addresses.
Ah, the systemic side.
Exactly. State-sanctioned violence systematically dismantles the rule of law. When authorities can violate the human body with impunity, the foundational trust required for civil society just collapses.
And that brings us directly to your duty as a practitioner. International forensic doctrine provides a very clear directive here. Every single forensic practitioner, and indeed every clinician, must be aware of the prevalence of these practices and must be prepared to raise concerns when any form of ill treatment is suspected.
It requires immense clinical expertise, certainly, but it also requires profound professional independence. You are serving as an evidential scientist. Your objective documentation might be the literal only safeguard a patient has against the unchecked abuse of power.
But to document it effectively, you can't just use standard medical terminology. You really have to speak the precise language of international law.
You.
Okay, let's unpack this. We need to master the medico-legal definitions. When international courts and tribunals adjudicate these cases, they rely on a highly specific classification system established by the International Committee of the Red Cross, the ICRC. This is Table 20.1 in your text.
We have to differentiate these terms with the exact same rigor we use to differentiate the cause, mechanism, and manner of death. Let's begin with the strict legal definition of torture.
Okay.
Under international frameworks, torture consists of severe pain or suffering, which can be either physical or mental. But the defining medico-legal pivot, the element that separates it from other forms of violence, is that this severe pain or suffering must be inflicted for a specific purpose.
A specific purpose. Okay, this is where the clinical history becomes just as critical as the physical exam. What kind of purpose actually elevates the act to torture?
The established examples include obtaining information, extracting a confession, exerting pressure, intimidation, or systemic humiliation. The presence of this deliberate, targeted intent by an official or someone acting in an official capacity is the absolute crux of the definition.
So intent transforms the legal category. That makes sense. Now let's contrast that with the second classification, which is cruel or inhuman treatment. And those are legally synonymous terms, right?
Yes, they are.
So how do they differ from torture?
Cruel or inhuman treatment involves acts causing serious pain or suffering, or acts that constitute a serious outrage upon individual dignity. But the critical distinction, the point you absolutely must remember for your exams and your tribunal reports, is that these acts do not require a specific purpose.
That is a massive distinction for the clinician to understand. I mean, you could theoretically have two patients with identical physical findings. Say both have acute closed compartment syndrome in their feet from blunt trauma. Both have severe psychological sequelae. But if patient A was beaten specifically to extract a confession about a political affiliation,
that's torture.
And if patient B was beaten simply because a jailer in a detention center was just arbitrary, sadistic, and completely lacking oversight.
The legal classifications diverge completely. The physiological mechanism of injury is identical. The resulting pathology is identical. But the legal framework categorizes patient A as a victim of torture and patient B as a victim of cruel or inhuman treatment.
Which means your job as the forensic expert is not to act as judge or jury. You just meticulously document the medical evidence and the detailed history so the court can accurately apply those definitions.
Exactly. Now let's look at the third ICRC definition: humiliating or degrading treatment. These are acts that cause real and serious humiliation or an outrage upon human dignity.
How do they quantify that legally?
The legal benchmark applied here is that the intensity of the act must be such that any reasonable person would feel outraged. It relies on a shared objective standard of basic human dignity.
Got it. And finally, we frequently hear the term ill treatment thrown around. Where does that fit?
Ill treatment functions as a non-legal umbrella term. It is a broad categorical phrase that basically encompasses all of the above: torture, cruel, inhuman, humiliating, and degrading treatment.
So once a clinician connects those dots, taking the history and recognizing the physical markers of state-sanctioned violence, they're faced with a pretty significant professional burden. I mean, the evidence has been identified. Where do you even begin to raise the alarm? How does the investigation process actually trigger?
Well, that depends entirely on the jurisdiction and the scale of the abuse. Forensic doctrine requires us to distinguish between single, isolated events and systematic abuses. A single event might be an unauthorized use of excessive force by an individual guard in a local prison.
Like a localized failure of discipline or protocol?
Correct. Contrast that with systematic abuse, which occurs as a matter of policy, whether that policy is officially written down or just quietly understood, at the behest of state institutions. Recognizing whether an injury pattern represents an isolated incident or a broader state mechanism is vital context.
And in terms of reporting pathways, if you are practicing in a jurisdiction with robust independent oversight, the pathway is pretty clear. In England and Wales, for instance, concerns regarding police custody are directed to the Independent Office for Police Conduct, the IOPC.
And issues within the prison system go to the Prison and Probation Ombudsman.
Right. These bodies exist specifically to investigate independently of the detaining authority.
But we have to acknowledge the global reality here. Many clinicians operate in environments where those independent state oversight mechanisms simply do not exist, or where the oversight bodies themselves are completely compromised.
When state mechanisms fail, who steps into the void?
Non-governmental organizations. The international framework heavily relies on bodies like the International Committee of the Red Cross, Amnesty International, Reprieve, and countless local independent human rights organizations.
And it is worth noting, purely as an objective reality of this field, that local human rights organizations and the physicians who work with them often document these state-sanctioned abuses at extraordinary personal and professional risk.
Oh, absolutely.
When you document the state mechanism of violence, you frequently invite the hostility of that state. You have to maintain a neutral, clinical tone without taking political sides, focusing purely on the medico-legal pathways of reporting.
Which underscores exactly why forensic documentation must be utterly unassailable. It must be so scientifically rigorous and methodologically sound that it simply cannot be dismissed as politically motivated or biased.
Brings us perfectly to the global gold standard of that methodology. The blueprint that every single clinician operating in this space must know, the Istanbul Protocol.
The formal title is The Manual on Effective Investigation and Documentation of Torture and Other Cruel, Inhuman, or Degrading Treatment or Punishment. It was originally adopted by the United Nations in 1999, and it underwent a massive, comprehensive update published recently in 2020.
Let's clarify its legal standing.
Yeah.
This is a really frequent point of contention in cross-examinations. Opposing counsel will often stand up and point out that the Istanbul Protocol is non-binding.
What's fascinating here is that, yes, it is non-binding in the sense of a strict international treaty. However, its forensic and legal weight is immense because it is the authoritative United Nations standard.
Right, it doesn't create new laws.
Exactly. It identifies the existing obligations states already have under established international treaties. It provides the definitive, universally recognized guidelines on exactly how to conduct effective legal and medical investigations.
So if a defense attorney attempts to dismiss your methodology, your anchor is that you followed the authoritative, globally recognized UN standard for clinical evaluation.
That's your shield.
The protocol is incredibly comprehensive. I mean, it covers ethical codes, legal investigation frameworks, general interviewing considerations. But for our specific clinical focus today, we are deeply concerned with its guidance on the assessment of physical and psychological evidence.
It standardizes the clinical vocabulary. If you submit a medical legal report to an asylum tribunal or an international court, and you have not structured your findings according to the Istanbul Protocol's methodology, your evidence is immediately vulnerable. The court literally expects this specific framework.
Okay, let's transition from the legal framework into the actual clinical environment. How do we approach the examination? What is the systematic approach? The protocol relies on the classic medical model you learn on day one of medical school: history, examination, diagnosis, interpretation, and management. This is table 20.3 for those following along.
It is a grounded, systematic structure. Chapter 5 of the Istanbul Protocol meticulously outlines the evaluation. It dictates the interview structure, the absolute necessity of separating acute versus chronic symptoms in the medical history, and a comprehensive head-to-toe physical examination.
We're talking dermatological, musculoskeletal, genitourinary, neurological, the works.
All of it.
But the real core of forensic expertise here is pattern recognition, driven by a deep understanding of pathological mechanisms. I mean, if you understand the physics of the weapon or the biomechanics of the stress position, the resulting clinical presentation makes perfect sense.
Let's start with the most prevalent form of physical abuse: blunt force trauma. We frequently see deep tissue damage, periosteel injuries, and highly specific dermal manifestations.
Yeah, let's look at figure 20.1 in the text. The classic forensic dermatological finding in blunt trauma from a flexible or rigid cylindrical object like an electrical cable, a baton, or a specialized whip is the tramline bruise.
Tramline bruises are incredibly distinct.
Let's break down the physics of a tramline bruise for the listener, because it is just an elegant demonstration of forensic pathology. When that cylindrical weapon strikes the human body, what is actually happening at the tissue level?
Okay, visualize the surface of the cylindrical weapon impacting the skin. It forcefully compresses the tissue directly beneath the exact center of the strike. Now, because blood is a non-compressible fluid, that immense downward pressure violently displaces the blood laterally.
It's squeezing the blood away from the center line.
Exactly, pushing it outward from the central point of impact. This sudden, high-velocity outward displacement of blood subjects the delicate capillary beds and venules at the outer margins of the strike zone to massive shear stress.
So the vessels at the edges stretch and rupture.
Yes, causing intradermal hemorrhage on the sides. Meanwhile, the tissue in the exact center, which took the absolute brunt of the compressive downward force, remains relatively exsanguinated during the millisecond of impact, so the vessels there actually don't rupture in the same way.
The result is two distinct parallel lines of bruising, the tram lines, separated by a central area of pale, relatively undamaged skin.
This mechanism is highly specific. When you observe tram-line bruising, you can confidently rule out a strike from a flat object, like a board or a fist or a broad fall against a wall. You are looking at a cylindrical weapon.
Furthermore, measuring the width of that pale central zone can provide an approximation of the weapon's diameter, which is a vital piece of scene correlation.
It links the injury directly to the implement. Now, let's examine a modality where blunt force is applied in a highly specialized, targeted manner: beating of the soles of the feet.
Internationally, this is known as Falanga or Falaka. The victim is usually immobilized, and the soles of the feet are repeatedly beaten with rods, sticks, or cables. Why is this specific method so globally pervasive?
From the perspective of the perpetrator, Falanga is chillingly effective. The soles of the feet possess an extremely high density of nerve endings, generating excruciating, blinding pain. But critically, it is designed to systematically destroy the victim's mobility,
Shattering their capacity to flee or function independently.
yes, while frequently leaving surprisingly subtle, superficial dermal evidence once the acute swelling subsides.
That's the terrifying part. The epidermis and dermis on the plantar surface are incredibly thick and resilient. They just don't lacerate or manifest ecchymosis as easily as the skin on the back or the face. So that absence of visible evidence rule becomes a massive factor here.
The real devastation is entirely internal. Let's discuss the acute pathophysiology. What is happening beneath that thick skin during the beating?
Well, the initial crisis is acute closed compartment syndrome. The foot, much like the lower leg, is architecturally divided into distinct fascial compartments. These spaces are enveloped by tough, highly unyielding connective tissue.
Right, the plantar fascia simply does not have the elasticity to accommodate rapid volume expansion.
Precisely. So as the blunt trauma causes massive intramuscular hemorrhage and aggressive edema, the volume inside these closed fascial compartments expands rapidly, but the compartment walls do not yield.
So intracompartmental pressure skyrockets.
And once that intracompartmental pressure exceeds the capillary perfusion pressure,
You induce severe ischemia. The venous outflow is occluded first, which obviously worsens the swelling, and eventually the arterial inflow is completely compromised. Blood supply to the intrinsic muscles and nerves of the foot is choked off.
this is an acute orthopedic emergency. I mean, in a normal clinical setting, this requires an immediate emergency fasciotomy to release the pressure. But in a torture setting, the pressure is left unrelieved,
Leading to profound cellular death. The ischemic muscle tissue undergoes necrosis. The nerves suffer ischemic neuropathy. And as the acute phase slowly resolves over weeks or months, that necrotic muscle is replaced by dense, non-functional fibrotic scar tissue.
which perfectly explains the chronic presentation. A clinician might examine a Falanga survivor years later. The skin on the soles might look relatively normal, perhaps just slightly thickened, but internally the architecture is ruined.
The foot becomes rigid. You will find irregular, deep fibrotic scarring that you can actually palpate. The intrinsic joints lose their mobility. Furthermore, the specialized loculated fat pads on the heel and the anterior foot, which act as essential shock absorbers during your normal gait cycle, are physically crushed and structurally obliterated at the cellular level.
So the patient is essentially walking bone on ground without any natural cushioning.
Every single step is agonizing. Add to that the high likelihood of a ruptured plantar aponeurosis from the extreme tension during the beating, leading to severe chronic plantar fasciitis. This is why a simple visual inspection is just woefully inadequate.
You absolutely must palpate, assess joint mobility, evaluate the gait, and understand the deep fascial destruction.
Exactly. Let's shift gears to another profoundly destructive mechanism that relies on biomechanics rather than direct blunt force: suspension torture.
There are brutal variations of this globally. You have cross suspension, reverse butchery, the Palestinian suspension, the parrot perch. What is the unifying physiological mechanism here?
Suspension torture essentially manipulates gravity and the victim's own body weight to inflict catastrophic damage to joints and neurovascular bundles, often without the perpetrator needing to strike a single blow.
We see this most commonly affecting the shoulder girdle. If you look at figure 20.3 in the text, it shows the disruption of the shoulder joint complex. The glenohumeral joint trades structural stability for an immense range of motion. It relies entirely on the rotator cuff musculature, the joint capsule, and the glenohumeral ligaments to maintain articulation.
So when a victim is suspended by their arms, particularly if the arms are bound behind the back in internal rotation, as seen in the Palestinian suspension, you are applying massive prolonged traction.
The entire gravitational weight of the body is pulling downward against fixed, elevated upper extremities.
The tensile stress on those supporting structures is immense. It far exceeds their physiological limits. You see micro-tearing, severe stretching, or complete rupture of the ligaments and rotator cuff tendons. The joint frequently undergoes subluxation or frank dislocation.
You will see gross anatomical deformities where the humeral head is completely displaced from the glenoid fossa.
But the orthopedic damage is only half the picture here. The neurological devastation is often permanent. The brachial plexus, that intricate network of nerve roots from C5 to T1 that innervates the entire upper extremity courses directly through the axilla.
Right, and prolonged, intense traction stretches the brachial plexus completely beyond its elastic tolerance. This traction injury can result in neuropraxia, where the myelin sheath is damaged, blocking signal conduction temporarily.
Or more severe force causes axonmesis, actually severing the axons themselves, or neuromesis, complete nerve avulsion.
Clinically, the survivor presents with profound peripheral neuropathy. They might exhibit severe burning dysesthesia, numbness, or frank paralysis of the arms and hands, classic Erb's or Klumpke's palsy presentations, long after the suspension is over.
Again, there might not be a single bruise or laceration on the skin, but the functional loss, the inability to grip a cup or lift their arm to comb their hair, that is the objective forensic evidence.
And this principle of unseen damage brings us to electrical torture. This is a modality specifically chosen by perpetrators because it inflicts agonizing pain while leaving minimal, highly localized physical markers.
Electrical modalities, whether via stun guns, bacana, or modified military field telephones, introduce a completely different pathophysiological mechanism. We are no longer talking about blunt force or traction. We are talking about electron flow through biological tissues.
The human body is essentially a volume conductor of electricity. When a current is applied, it seeks the path of least electrical resistance. Blood vessels and nerves, being highly aqueous and electrolyte-rich, offer the least resistance.
So the current preferentially travels along those neurovascular bundles.
What does that current do at the cellular level?
The rapid influx of electrical energy causes extreme depolarization of cell membranes, leading to violent, uncontrolled muscle tetany. This tetany can be so severe it actually causes secondary fractures or joint dislocations purely from the force of the victim's own muscle contractions.
That's horrifying.
Furthermore, alternating current is notoriously arrhythmogenic, frequently inducing ventricular fibrillation or sudden cardiac arrest right there during the interrogation.
But forensically, what are we looking for on the skin? Where the current enters and exits?
Yes, the electrical energy converts to thermal energy at the points of highest resistance, the epidermis. You are looking for jewel burns. These are often tiny, pinpoint lesions, maybe only a few millimeters in diameter.
They can be incredibly easy to miss if you aren't doing a meticulous, systematic dermatological exam.
They initially present as small, clustered, erythematous macules that progress to crusted, umbilicated lesions. Histologically, if a biopsy is taken early enough, you might find metallization.
Microscopic deposits of the metal from the electrode embedded in the epidermis due to the electrical arcing.
Exactly. But crucially, skin resistance plummets when it's wet. If the victim is sweating profusely from terror, or if water is intentionally applied, the electrical current disperses much more easily, causing deeper internal tissue damage, but leaving even less thermal burning on the skin surface.
Absence of evidence again. Which leads us to positional torture in stress positions. Prolonged standing, forced squatting, being confined in boxes too small to sit or stand in. These seem, less immediately violent than electrical shocks or Falanga, but the systemic physiological collapse they induce is profound.
Positional torture weaponizes the body's own fatigue. Take forced prolonged standing. Gravity demands that venous return from the lower extremities requires the pumping action of the calf muscles. When a person is forced to stand absolutely still for days, massive venous pooling occurs.
You get severe lower extremity edema, but more dangerously, you get systemic hypovolemia as fluid shifts into the interstitial spaces.
Exactly. But the most critical forensic consequence of stress positions, such as forced prolonged squatting, is rhabdomyolysis.
Right.
The constant, unrelenting isometric contraction of the quadriceps and gluteal muscles causes the muscle cell membranes to essentially fail. The cells rupture, spilling their contents directly into the bloodstream.
Including large quantities of myoglobin.
And myoglobin is highly nephrotoxic. The massive myoglobinuria hits the kidneys, precipitates in the renal tubules, and triggers acute kidney injury or complete acute renal failure. So the clinical evidence of a stress position might not be a mark on the skin at all. It might be profoundly elevated serum creatine kinase, dark urine, and acute uremia.
This integration of pathology and internal medicine is exactly what advanced forensic evaluation requires. You must look beyond the skin. And nowhere is that more terrifyingly evident than in asphyxiation torture.
Asphyxiation is the ultimate psychological and physiological terror because it directly simulates the dying process. Modalities include dry submarino, where a plastic bag is tied over the head, and wet submarino, which is essentially forced submersion or waterboarding.
Let's discuss the physiology of wet submarino. The sudden influx of water into the oropharynx triggers the laryngeal reflex.
The vocal cords spasm shut to protect the airway larynxspasm. This prevents water from immediately flooding the lungs, but it also completely halts ventilation. The victim rapidly develops severe hypoxia and hypercapnia.
The rising carbon dioxide levels in the blood trigger an agonizing, insurmountable, primal drive to breathe, but they simply cannot.
From a forensic perspective, what physical markers actually remain? They can be incredibly sparse. You might find petechial hemorrhages in the conjunctivae or the mucosal surfaces of the mouth due to the extreme spikes in venous pressure during the struggle against the asphyxia.
You might find minor abrasions around the mouth, nose, or neck where bindings or hands were applied, but frequently there is no distinct dermatological evidence whatsoever.
The evidence is often neurological and psychological. Repeated hypoxic episodes cause cumulative cerebral ischemia. Survivors often present with chronic headaches, profound memory deficits, personality changes, and early-onset cognitive decline, absolute hallmarks of anoxic brain injury.
And we must briefly mention dental torture, which is common because the teeth are highly innervated and easily accessible. Forced extractions without anesthesia, fracturing teeth with blunt instruments, or applying electrical current directly to the dental pulp.
The forensic odontologist becomes vital here, documenting missing dentition, alveolar bone fractures, and root damage that simply cannot be explained by standard dental decay or poor hygiene.
Every modality we have discussed requires a deep understanding of pathophysiology. But we must now address an area where the physical medical evidence is often the most fleeting, yet the trauma is the most profound.
Sexual torture, including rape and sexualized violence.
The international medical consensus, clearly outlined in the Istanbul Protocol and established forensic literature, presents a critical reality that every practitioner must internalize. Penetrative sexual contact leaves visible physical evidence in only a minority of cases.
Let me reiterate that with absolute clarity. Penetrative sexual violence leaves visible physical evidence in only a minority of cases. Furthermore, when acute physical injuries do occur, such as lacerations, abrasions, or ecchymosis to the vaginal or anal mucosa, the physiological nature of these tissues works aggressively against forensic preservation.
The mucosal tissues are highly vascularized. They regenerate and heal extraordinarily fast compared to keratinized skin.
The clinical time frame is vital here. Acute injuries to the anogenital mucosa frequently heal completely within roughly 72 hours.
3 days. If a survivor is detained in a black site, a prison, or an immigration center for a week or a month before they are finally granted access to an independent medical professional, that acute physical evidence is entirely gone.
Completely resolved. This is why a negative physical examination does absolutely nothing to invalidate a credible, detailed history of sexual assault. If a clinician writes, "No evidence of assault found," based purely on a normal mucosal exam 3 weeks post-incident, they are not only medically inaccurate, they're providing ammunition for the perpetrator to dismiss the claim.
The documentation must reflect the physiological reality. You state, the examination revealed no acute physical trauma, which is entirely consistent with the time frame described, as mucosal injuries heal rapidly. It is about understanding the limitations of the physical exam.
Because the physical evidence is so transient, the psychological evidence and the manner in which the history is obtained become the central pillars of the evaluation. You cannot approach this like a standard clinical intake. You absolutely must utilize trauma-informed interviewing.
Trauma-informed care recognizes that the interview itself can be profoundly re-traumatizing. The survivor was subjected to a total loss of autonomy. The medical evaluation cannot replicate that power dynamic.
You have to restore agency. It starts before you even ask a single question. allowing the patient to choose where to sit, explicitly stating that they are in control of the pace, that they can refuse to answer any question, and that they can halt the examination at any moment without penalty.
And there are massive complexities when utilizing interpreters. The protocol is clear. You should never use a patient's family member or a community acquaintance to interpret, particularly in cases of sexual torture due to shame, cultural stigma, or fear of reprisal.
You need a professional, independent interpreter. You must ensure they speak the exact dialect, and crucially, you must be hyper-aware of political or ethnic divides. Providing an interpreter who belongs to the same ethnic or political group as the perpetrators will immediately shut down any truthful disclosure.
Once that safe environment is established, you are evaluating the psychological sequelae. Torture is designed to dismantle the personality.
The psychiatric footprint is often much larger than the physical one. We are looking for classic post-traumatic stress disorder, hyperarousal, severe intrusive flashbacks, emotional numbing, and active avoidance of triggers.
But we also see complex PTSD, which arises from prolonged, inescapable trauma. This manifests as severe emotional dysregulation, chronic dissociation, and a fundamental distortion of the patient's core identity and trust in humanity.
We also frequently encounter severe somatic symptom disorders. The patient presents with intractable, generalized chronic pain, gastrointestinal distress, or pseudoneurological symptoms that have no clear organic cause on imaging, but are the physical manifestations of profound psychological trauma. Documenting these psychiatric and somatic symptoms with the exact same rigor as a broken bone is essential.
Let us turn to an aspect of the clinical evaluation that is deeply disturbing but absolutely necessary to recognize. I want to discuss the forensic implications of surgically precise injuries. For example, look at figure 20.2 in the text. It's evaluating an amputated digit, a right thumb, where the surgical margins are exceptionally neat.
The clinical observation of clean skin flaps, organized closure, and appropriate management of the neurovascular bundles during an amputation performed as punishment.
This specific forensic finding forces us to confront the reality of medical complicity. When an injury indicates advanced anatomical knowledge, the use of local anesthesia or surgical suturing techniques, it strongly suggests that the mutilation was performed or supervised by a trained healthcare professional.
It represents the complete inversion of the clinical mandate. Medical skills utilized not for healing, but for the precise, efficient infliction of irreversible disability and pain.
From a forensic standpoint, recognizing and documenting the neatness of that scar or the surgical precision of an injury is crucial. It serves as powerful evidence of the systematic state-sanctioned nature of the abuse. It proves the state apparatus utilized its own medical professionals to facilitate the torture.
It is a heavy reality for any clinician to document, but it reinforces exactly why your role must be strictly objective, which leads us to the final, critical phase: interpretation and medico-legal wording. You have gathered a trauma-informed history, you have conducted a systematic examination, you understand the complex pathophysiology of the injuries. How do you translate this into a medico-legal report that will withstand cross-examination in an international tribunal?
So what does this all mean for you, the practitioner writing the report? The paramount requirement is uncompromising, non-biased objectivity. The adjudicating bodies, judges, asylum panels, immigration officers will only accept your findings if you are clearly operating as an impartial scientist, not as an advocate.
And true objectivity requires acknowledging that while the vast majority of findings corroborate the history, discrepancies do occur. Accounts might be false due to an intention to mislead, poor recall, or mental health issues. You must evaluate every lesion independently.
Is the scar acute or chronic? Does the maturation of the scar tissue match the timeline provided in the history?
You must also diligently distinguish between injuries caused by the alleged ill treatment and those resulting from other etiologies.
You are basically building a differential diagnosis for a scar. Could this be the result of a cultural practice like traditional cupping or tribal scarification? Could it be an occupational hazard, a sports injury, or a childhood accident?
Exactly. And to maintain absolute precision, the Istanbul Protocol prohibits vague language. You cannot write, "The scars look like they're from torture." You are required to use a highly specific, standardized, 5-tiered consistency scale for every single physical and psychological finding.
Let's walk through this 5-tiered hierarchy. This is table 20.4, because this is the exact language you must use in your reports and exams. Tier 1, not consistent.
Not consistent means the lesion could not have been caused by the trauma described.
So if a patient reports being burned with a heated iron 1 week ago, but upon examination you find a fully matured, hypopigmented, flat scar, that is clearly several years old.
That finding is not consistent with the timeline of the history provided. It physically could not have happened as described.
Tier 2. Consistent with.
Consistent with means the lesion could have been caused by the trauma described, but it is highly nonspecific and there are many other possible causes.
For example, a diffuse resolving ecchymosis on the anterior tibia. The patient states they were kicked by a guard's boot.
The bruise is absolutely consistent with a kick from a boot, but a diffuse shin bruise could also be caused by stumbling against a bed frame, playing football, or a minor trip and fall. It aligns with the history, but it lacks specificity.
Moving up to Tier 3. Highly consistent.
Highly consistent indicates the lesion could have been caused by the trauma described, and importantly, there are a few other possible causes. The differential diagnosis is narrowing significantly.
This is where our tramline bruises apply. The patient describes being struck repeatedly with an electrical cable. You observe distinct tramline bruising on the posterior thorax. Could it be a bizarre, perfectly angled fall against two parallel bars? Perhaps. But there are very few mechanisms outside of a strike from a cylindrical weapon that produce that specific lateral displacement of blood. It is highly consistent.
Tier 4. Typical of.
Right.
Typical of means this is an appearance that is usually found with this specific type of trauma. It is the classic textbook presentation.
Think of specific thermal blanks. A patient reports being tortured with lit cigarettes. You observe a cluster of circular punched-out scars precisely 8 millimeters in diameter with a slightly hyperpigmented rim.
That specific size, shape, and clustering pattern is the hallmark of a cigarette burn. While another perfectly circular 8-millimeter heated rod could theoretically cause it, the presentation is typical of cigarette burns.
And the final tier, the absolute strongest level of forensic conviction. Diagnostic of.
Diagnostic of means this appearance could not have been caused in any way other than that described. It is definitive.
This is a remarkably high bar to clear in forensic medicine. Like a 100% confidence interval.
It is rare. You reserve this for absolute certainty. For example, a radiographic series reveals a specific, uniquely manufactured piece of shrapnel embedded in the femur that metallurgical analysis matches perfectly to a specific state-issued munition described by the victim, or a thermal brand mark that perfectly mirrors the intricate logo of a known state detention facility. It cannot be anything else. It is diagnostic.
You must force yourself to categorize every individual mark, scar, and psychiatric symptom into one of these 5 tiers. This discipline is what separates a subjective clinical opinion from an unassailable forensic evaluation.
It provides the court with the precise, probabilistic weight of the medical evidence.
We have covered an immense amount of complex, heavy material today. To ensure these concepts are anchored for your clinical practice in your exams, we're going to finish with our learning reinforcement. We have a series of rapid, single best answer style prompts based on the mechanisms and frameworks we've discussed.
I will present the clinical question. We will pause briefly to let you synthesize the answer, and then I will reveal the answer, the reasoning, and the area of the chapter to review if needed.
Let's do it. Question 1.
Under the ICRC definitions, what specific legal element must be present to elevate an act from cruel or inhuman treatment to the classification of torture?
Take a second to think about the distinction.
The answer is the infliction of severe pain or suffering for a specific purpose, such as obtaining a confession or exerting intimidation. Cruel or inhuman treatment lacks this specific intent requirement. Revisit Table 20.1 if you need to solidify this distinction.
Excellent. Question 2.
A forensic physician submits a medical evaluation of a torture survivor to an asylum tribunal. Which United Nations document provides the authoritative, globally recognized methodology that the court will expect this evaluation to follow?
We stress the name of this protocol heavily.
The answer is the Istanbul Protocol. Remember, while non-binding as a treaty, it is the authoritative standard for clinical and legal investigation. Revisit the Istanbul Protocol section.
Question 3.
You are evaluating a patient who is subjected to Falanga. Based on the pathophysiology of blunt trauma to the plantar surface, what acute orthopedic emergency is the patient at highest risk for during the beating?
Think about the anatomy of the foot.
The answer is acute closed compartment syndrome of the foot. The unyielding nature of the fascial compartments leads to rapid ischemia and subsequent muscle necrosis if the intercompartmental pressure is not relieved. Revisit Table 20.3.
Question 4.
A patient is suspended by the arms, which are bound behind their back, for 48 hours. 3 months later, they present with severe weakness, numbness, and burning pain in their right hand, with no visible dermal scarring. What specific anatomical structure was likely damaged by the prolonged traction?
Hanging body weight on the shoulder girdle.
The answer is the brachial plexus. The traction forces stretched the nerve roots, causing neuropraxia or axonotmesis, leading to chronic peripheral neuropathy despite the absence of skin lesions.
Question 5.
You are examining a survivor of alleged sexual violence in a detention center. The assault reportedly occurred 2 weeks prior. Your examination of the anogenital mucosa reveals no acute lacerations, bruising, or abrasions. According to established forensic doctrine, within what general time frame do acute mucosal injuries typically heal?
This is a crucial timeline to remember.
The answer is within 72 hours. Because the mucosa is highly vascularized, acute injuries resolve rapidly. A negative physical exam weeks later does not invalidate the history. Revisit the interpretation section.
Questions.
During an assessment, a patient states a guard struck them violently across the back with a dense electrical cable. On examination, you note 2 parallel lines of intradermal hemorrhage separated by a pale, undamaged central area. What specific forensic term describes this dermatological finding?
Think of the physical shape it leaves.
The answer is a tramline bruise. The cylindrical weapon laterally displaces blood upon impact, rupturing marginal vessels while sparing the center.
Question 7.
A survivor of prolonged stress positions, specifically forced squatting for 3 days, presents with dark urine, profound weakness, and elevated serum creatinine. The sustained isometric muscle contraction likely caused the systemic release of what nephrotoxic protein?
Muscle breakdown.
The answer is myoglobin, secondary to rhabdomyolysis. The muscle cell membranes fail under prolonged stress, releasing myoglobin, which precipitates in the renal tubules.
Final question. Question 8.
You observe a perfectly circular 8mm punched-out scar with a hyperpigmented rim on a patient's arm. The patient reports being burned with a cigarette. Under the Istanbul Protocol's consistency scale, how would you classify this specific lesion?
Tier 1 through 5.
The answer is typical of. The size, shape, and presentation represent the classic expected appearance of a cigarette burn. Revisit Table 20.4 for the scale.
That concludes our reinforcement questions. Thank you for staying with us through this incredibly dense, demanding session. We have mapped the global landscape, dissected the legal frameworks, detailed the complex pathophysiology of specific modalities, from compartment syndrome to brachial plexus traction, and reviewed the strict forensic language required for court. Remember, use this conceptual foundation to support your reading of Chapter 20 in Simpson's Forensic Medicine.
As we conclude this session, I want you to step back from the specific mechanisms and consider the broader clinical picture. We spend years training our eyes to find the physical pathology, the tramline bruise, the crushed fascial compartment, the discrete jewel burn. But the true mastery of forensic medicine in the context of human rights is recognizing the devastating weight of the invisible trauma.
That is profound.
Consider the psychological burden carried by the survivor whose physical wounds have long since faded. And consider your profound responsibility as the practitioner tasked with translating their silent, unyielding suffering into a rigorous, objective language that international law cannot ignore. As you move forward in your clinical practice, ask yourself, how do you document the destruction of human dignity when the body has healed but the mind has not?
Thank you for being here. Keep questioning, keep studying, and remember the massive impact your documentation can have.